Be here, and I'm going to make this very brief. I was asked to talk about surveillance after below-knee intervention. Should I do it at all, and should I intervene for asymptomatic restenosis? So I think after post-revascularization, I think the way we look at successful interventions and then follow-up is non-invasive testing, medical therapy, and wound care. I'm not going to talk about those two areas, but certainly non-invasive testing is a hotly debated issue. Here in the United States in 2010, there was a performance measure document published by multiple societies, including the American Heart Association and American College of Cardiology and SCA&I. And in this, there was a statement about the use of ABI and duplex testing for surveillance of venous bypass conduits. In the document itself, it basically emphasizes that the literature does not strongly support duplex ultrasonography for surveillance of prostatic bypass. On the other hand, that seems to be a common practice. It certainly suggests that it's acceptable in certain patients, particularly those with autologous venous segments. In 2012, an appropriate use criteria document fell on the heels of this, and this had implications for reimbursement for this procedure and for the surveillance ultrasonography. And again, when looking at the AUC criteria using the old nomenclature, it was relatively unclear as to whether a Doppler should be performed for an asymptomatic or stable patient. It was reasonable and appropriate for a baseline within a month after intervention, and if they had new or worsening symptoms, to perform imaging. But really, beyond that, it's anybody's guess as to what is the appropriate surveillance. And so there remains lack of clarity about what the standard of care should be. In this context, if we look at people with below-knee interventions, most of those patients overwhelmingly are being treated for critical limb ischemia. And there's been a number of small case series and reviews, and this, I thought, was perhaps the most credible meta-analysis of these data, looking specifically at wound healing in diabetic feet, perhaps our highest risk substrate. And when looking at tests for prediction of wound healing throughout all of these studies, ABI and TCPO2 came out on top in terms of sensitivity and specificity, but you can see that the overall sensitivity and specificity remains relatively poor. TCPO2 perhaps better, with sensitivity of 72% and specificity of 86%. But these are relatively poor surrogates for wound healing. So as you've heard already today, there's very little in the way of good data. So we're left with this concept in most critical limb patients that the reason to do surveillance is to assess patency. But if one assumes that you've had a situation here where chronic ischemia is outstripped by the metabolic demand of an injury, and then after you've achieved wound healing, the metabolic demand goes back to baseline, the patency may or may not matter. And this is sort of where many people lie in this conversation, that it doesn't matter if the patient has restenosis as long as they're clinically asymptomatic. The problem is, in my clinical practice, what we see over and over again is that people come back with recurrent critical limb ischemia, and we wind up having to go back in for an intervention. And one wonders if, in fact, if we had done better surveillance, we'd be able to prevent that. So there, in my clinical practices, and this is based up on nothing more scientific than me writing down what I do, in our clinical practice, we get a baseline study with a TBI within 30 days of the procedure, and we do clinical follow-up both in the wound clinic and with the proceduralist in parallel subsequently. Routine surveillance is done per guidelines, which is to say we do it at our discretion, usually at 6 and 12 months with Doppler and physiologic testing. If the wound healing trajectory is not consistent with my expectations, then we will actually do additional testing and have a low threshold for repeat angiography or intervention. If the wound healing is satisfactory and or if the patient is asymptomatic, we'll elect to just surveil without any response to the surveillance. And I'll show you what I mean in two case examples. This is a 91-year-old patient who had second toe osteomyelitis and was referred from the podiatrist to us for evaluation prior to toe amputation. Her ABI was 0.36 with a monophasic waveform, and her toe pressure was measured as 0, undetectable, with an ankle pressure of 70. So significant intrapedal disease. This is what her foot looked like at the time. She had reasonable above-knee flow, but not surprisingly, once we got down to the tibial vessels, she had no name vessel continuously feeding the foot, and the dominant vessel was the anterior tibial. So after an intervention where we were able to restore foot perfusion through the posterior tibial, and for a lot of reasons the AT was unsuccessful, she had these hemodynamics: toe pressure of 40, ankle pressure of 100, and a TCPO2 of 40. And we cleared her to have the amputation done and was put on antibiotics, and she successfully healed and ultimately closed this wound. And to this date, actually, she's about 95 years of age and still going strong. In the last case I'll show, it's a 68-year-old diabetic with good control and risk factors who had a hallux ulcer, similar low TBI and toe pressures with waveforms as shown here, with relatively clean inflow again, and just take my word for it, extensive tibial disease with poor runoff. So poor, in fact, that on this resolution you can't even see it. But take my word for it, she had incomplete runoff to the foot. And after revascularization, we're able to get the AT open and the PT and have perfusion. And she healed almost immediately. Her symptoms resolved, and she healed in 4 weeks with serial follow-up. About 12 months later, she was asymptomatic, and the Doppler showed occlusive restenosis, and we didn't respond to this. In fact, we let her continue with surveillance and appropriate foot orthotics. So I would summarize that I think in this field, there's relatively little consensus about how to manage the patients. As a matter of form, I do perform surveillance, if nothing else, as a way to get the patients back for serial follow-up. And then it's really up to us to interpret their symptoms and their wound healing before we decide on re-intervention. Thanks very much.